Hi, everybody. This is Laura Doherty from the Functional Formularies team. Thank you so much for joining us today for our webinar. I apologize for the few-minute delay, but no worries. We have a full, action-packed, super informative webinar planned for you today. Before we get started, though, I will say this has been approved for one CPE from the CDR. So after today's webinar, you will get an email with a link to your certificate, the references, as well as a post survey that we hope everybody will fill out to give their honest feedback about today's webinar. We will have some time at the end for Q&A. So when we get to that point, or even throughout the webinar, please, you can answer questions in the question feature on this webinar, and we'll get to as many as we can. We ask that everybody please stay muted throughout the webinar so there's not any of those interferences. And I think those are all my housekeeping rules or things. So I will introduce our amazing speaker today. So we have Haley Riggs, who is a RD with a Bachelor of Science and a Master of Science in Nutritional Sciences from Oklahoma State University. Haley holds a clinical specialty in pediatric nutrition. She currently is a clinical dietitian at the Warren Clinic Pediatric Gastroenterology office in Tulsa. Here, she specializes in patients with G-tubes, accounting for almost 90% of her patient load. So with that, I'll hand it over to Haley. Haley, will you put it on presenter, or like we can see, what's the right word here? The full slideshow, like presenter view?
Oh, sure.
Yeah. Perfect. Okay, with that being said, Haley, the floor is yours. Thank you so much for sharing your knowledge and time today.
Okay. Thank you, Laura. Thank you all for being here. I'm going to turn my camera off. All right. Yeah. So I'm happy to try to share, upwards to almost 10 years experience now of working with kids and G-tubes and G-tube feedings and, navigating transitions. I feel like this is always so tricky. And so it's always nice, in my opinion, to hear it come from somebody who's done it, especially if you're new to working clinical and things like that. A couple of disclosures. I am a consultant for the Functional Formularies and received a speaking honorarium for today's event. So let's dive into the objectives of today. So goals: understand the indications for enteral nutrition and access, the safety and appropriateness of initiating tube feedings, gain techniques and strategies for transitions, understanding best practices for transitioning between different formulas, including introduction of whole food to a feeding regimen, and then discuss strategies for evaluating patient readiness and supporting the transition from tube feeding back to oral intake, because that is just as important as it is, giving these tube feedings. I didn't realize when I first started here at the GI clinic how much my goal would be to get kids off of tube feedings. So that's hopefully for a lot of patients the ultimate goal. So we'll talk a little bit about that too. So this should be a little bit of a review. These indications for enteral nutrition come from the Texas Children's Hospital Pediatric Nutrition Reference Guide. If you guys aren't using this, this is an incredible tool, an incredible book. I call it my nutrition Bible. Lots of plethora of information, regimens, and just recommendations for different things. So indications for enteral nutrition: inadequate oral intake due to behavioral, anatomical, developmental concerns, increased needs, malnutrition, risk for aspiration, or compromised altered GI function. And this, I'm sure many of you guys have encountered these patients. Contraindications: lack of safe access, GI dysfunction, with the list of things here. May not be appropriate for patients with hemodynamic instability, concerns for poor GI perfusion. I've come across some of these patients in working in the pediatric ICU more often than outpatient. Okay, so during some of my lit review for this presentation, I found kind of a nice little study. They did a survey for nasogastric tubes versus gastrostomy tube and when to transition. Personally, I found this kind of interesting. I feel like NG tubes can be tricky, but it was interesting to find this review to give you some kind of, sort of like parameters or a guideline as to when NGs could be more helpful or more beneficial or even worth trying versus G tubes, and like kind of what that might look like in terms of like a flow chart in terms of trying to find which one and when to transition. So I thought it was worth talking about. So the study was published in Aspen in 2021, transitioning from nasogastric feeding tube to gastrostomy tubes in pediatric patients, a survey on decision making and practice. So it was a lot of feedback from families as well as practitioners. So this chart is indicating or showing the NG tube use, placement, and care in the home. So indications for using an NG tube at home. The 92% of the responses were short-term enteral support is needed, which I think we're all pretty familiar with as being the reasoning for using NG tubes. But I do think it's interesting to note short-term for them resulted of the survey indicated that 3 months of NG tube was more typical before considering a G tube placement. So I feel like sometimes in the lives of families, 3 months is not short term. So it's just a nice, almost reassuring that, you can potentially try to be using these G tubes to make progress where clinically for more than like weeks, Some of the other responses were 50% long-term enteral nutrition is required because of self-limiting illness. Child will have surgery in the next 6 months and will be able to eat after that. That's probably one of the bigger indications that I've seen personally is, you've got a patient that's swallowed a sequin star and it really, really wreaked havoc on their esophagus, and they're gonna need an alternate route. But that's supposed to heal and get better, and they're supposed to move on with life. So it's kind of something that you're looking forward to get, or like a bridge, but that's usually what I see. These other things are if checking pH when parents do this, in-home NG feeding is offered in your setting, where's the follow-up? My takeaway from this is that you definitely, if this is something that you can consider doing with patients, you also need a lot more support and training and education availability to these families in terms of like checking the placement of these NG tubes at home and kind of reassuring providers that it's safe and they can do that. And we'll talk about that on this next slide. But like where I'm at, our resources for this are limited. We don't have a lot of nursing staff in clinic, and the children's hospital I work with has kind of some limited availability for something like this specifically in an outpatient basis. So it's interesting, like this, trying to move forward in something like this for NG tubes definitely takes more than just like, I think you're a good candidate for it. We got to have support for that too. But I do get here a lot of hesitation from providers, nurses, going home, families, is it safe? So the same article did a review to find the NG safety at home. They found one article described symptoms with NG tubes were essentially associated with underlying medical conditions, so not necessarily because the tube was there. 3 papers explored readmissions for NG tubes, and none found any risk for readmissions. 96% of parents felt the home NG tubes were safe. And no study clearly describes significant complications associated with parent placement in G tubes. That's kind of the obstacle we run into a lot, is when we're sending in homes with NG tubes, inevitably, especially depending on the age of the patient, you're right back in the ER the next day because it got pulled out. So definitely interesting information to have found, around the nation, that it can be safe, parents can be taught, and it can be an option. The same article gave this flow sheet in terms of like NG tube to G tube decision making, which I'm sure, you know, instinctually with everybody's training, this is kind of the process that you guys would go through on your own. But it's nice to and reassuring to see it in literature, I always think. So there is this decision making tree out there, especially for people who maybe haven't done this before. So, you know, in summarization, I think a lot of this is related to parent and provider placement. So it's kind of like, let's see how far and how much progress we can make with an NG tube and avoid a surgery if the parents are still comfortable with it. I wanted to point out the second rung in the chart, consult feeding services and feeding therapists. And we'll talk a little bit more about that later, but that I think is a vital role and something that needs to happen in all these kids that have the potential to eat by mouth. And we'll talk a little more about that later. But I would say this is tricky, and like on this slide, barriers to transition from NG tubes to G tube. You know, if the NG tube's not working, then we're going to need a gastrostomy tube placed by surgery. And sometimes that's where in my experience, I've gotten stuck with some families, you know, wanting to hold out and not have the surgery or not move on. But this gives you an idea. So some of the parent caregiver barriers think that G2 placement is a permanent something permanent that can't be removed. So we're always trying to tell our families with the potential that they might not need it for, you know, the duration of their life, that this is something as, you know, a tool, an additional tool in our tool belt to help, you know, work on oral feedings or work on our nutrition status and just work on our weight gain and see what happens, you know, 1 or 2 years. But I do think that's an important conversation to have at the beginning of this journey when it comes to like deciding on it, trying if an NG tube is helpful. Some of the other barriers relate to placement will be further decline of oral feeding, which I would hope most of us know that that's certainly not the case. I find it can be helpful and an improvement, especially takes the stress off of oral feeding in terms of like meal times and making sure kids are eating enough. And surgery fears, of course, that's common. We send all of our kids to surgery for referrals to talk about the placement of this before it happens, ideally, especially in a situation if they're in NG. Yeah, so sometimes this can be the tricky part is NG feeds I think can be helpful, but it's when it's not helpful, how do we you know, move forward? A case study that I wanted to share, similar kind of situation, and I'll be sharing different case studies that I personally have experienced throughout the presentation. So this is a 4-month-old, male, 36-week gestation, IUGR, had a PDA and PFO on his like initial echo in his NICU stay. Came to our clinic for slow weight gain at 2 months of age, failed multiple formula changes and calorie concentrations. When he saw us, I think first his average weight gain was 8 or almost 10 grams today for just a 7-day average, but you know, goals at this age are much higher, especially being small. His like weight for length Z-score would have put him at like a moderately malnourished state. So of course, we first started out with testing to see if there's any anatomical problems to interfering with him eating more by mouth or gaining weight. His upper GI was normal. His dysphagia, or his like barium swallow, showed mild aspiration risk and aspiration precautions, but no change in his liquids. So at the time, our goal was to place an NG and optimize his nutritional intake and see if this helps his weight gain or his oral intake, because, you know, with this testing, we weren't concerned that there was some kind of safety issue or anatomical problem as to why he wasn't taking more in, but we needed to promote some more weight gain. So we decided, let's place an NG. We'll try this. We'll see if his oral intake is improved. We'll get a surgery referral. we actually struggled to get him to gain weight with an NG on his own. So he ended up having an echo done, but all while still getting NG tube feeding. So trying to optimize that throughout the testing that we had before he had his G tube placed. So I thought this was helpful. This is definitely an easier or a more efficient way to get formula or nutrition into a kiddo that you need to be growing quickly based on them coming to you and their history. So ultimately, we decided on G2 placement for him. So that kind of moves us into our next transition. G2 placement, kind of like a hospital course. I don't know how many of you are working in hospitals or have worked in hospitals. So this is kind of just like a very short review of like maybe what would happen while your patient getting a G-tube is in the hospital. So here in Tulsa, surgery places all of our G-tubes inpatient. They stay a couple days. And in my experience, kind of the GI teams or even the surgery teams have feeding advancements after tube placements, to which, I mean, 10 years ago I was more involved in, and then we've grown as like a group, and so there's been more people to take over that for me. So it's kind of not, it doesn't have to be dietitian dependent, really. A lot of it is kind of protocols to help patients, tolerate things and move on and discharge. But this is kind of a advancement recommendation from the Texas Children's Nutrition Reference Guide. Gives you an idea of like ages, how to start, how to advance, and suggested max volumes per kg, which as a dietitian starting out, I thought was very, very helpful, because I feel like that sometimes that's the hardest question when it comes to tube feedings is like, well, where do I start? So this can, just know there's a reference out there. This can help you in terms of age, and then even where to start and how to advance. Yeah, so say our patient is doing well. This is Aspen Safe Practices for Enteral Nutrition Therapy. So what are potential criteria and factors to consider to safely transition a patient from enteral from the hospital to home or an alternative care site? Again, great resource if you've got multiple people asking you questions like, oh, well, can they go home? Are they ready to go home? So these are just some recommendations that you can kind of check boxes off of the list in terms of saying like, yeah, they're great, they're doing well. So number one, obviously establish tolerance to enteral nutrition at the goal regimen prior to discharge. So number one goal. And then these other goals, honestly, I wrote down, you should hopefully have other team members helping you out to facilitate these goals in terms of like ordering supplies and accessing a safety home environment, making sure the patient caregiver demonstrates competencies. Like, I would hope that you have other team members to help you out with some of these educations and whatnot. But if not, you're an all-star, and these are some of the things that you can check off your list before you can deem them worthy to leave. Another resource is tubefed.com. I don't know how many of you guys are familiar with this. It does have clinical education, patient resources, clinician resources, and troubleshooting for all things G-tubes. I think it's actually, I like this website in terms of even if you as a practitioner want to familiarize yourself with like what these tube looks like on the inside, where, what you're putting into them and sizes and links and, the balloons and the, or even like pump feedings. There's tons of videos on this website to help you kind of have more of a well-rounded knowledge of what goes on in terms of like these tubes, because yeah, ideally we're just the people that are like telling them what to put in the tube, but it's obviously much more helpful to know the entire story here. But this is a great resource, especially even for parents in terms of like troubleshooting clogs and things like that. They have great videos. Okay, so now we're going to transition to life at home with a feeding tube. So now we're on our feeding tube journey. So things to consider: obviously weight change since you started your tube, feedings and tolerance. Are we having vomiting? Are we having reflux? Like, these are the questions I'm asking myself as I'm seeing a patient for the first time since they've been discharged. A hospital discharge plan, if you're like privileged enough to know what that discharge looked like, that's lovely, and like know what they left on, know what they tolerated, know what they didn't tolerate. You know, taking that into account. Also, you know, other specialists that are involved, upcoming appointments, upcoming surgeries, like, do we need to wait 8 weeks before they have a palate repair and do what we've been doing, or can we change things up, or, you know, things like that are things to consider when you're seeing them for the first time and trying to transition to feedings at home that can be more, you know, convenient or more appropriate for a home situation versus like 24-hour care in the hospital. So bolus versus continuous, you know, in the facility I worked at, your new G2 patients, they were going home on continuous feedings, mostly just because, you know, theoretically that's easiest to tolerate, and then they're discharged sooner. So I would venture to bet a lot of times that if you were in an outpatient setting, this patient might be coming to you on continuous feedings. But if not, we're weighing the options on, like, can we stay here? Can we do boluses? Are the boluses working? You know, things like that. So this again is from the Pediatric Nutrition Reference Guides from Texas Children. So potential advantages and disadvantages for boluses and continuous feedings. So bolus wise, it's more physiologic method of feeding. You have more mobility, increased flexible schedule, which we can talk about a little bit more, decreased hang times. This is kind of easier to be used with oral feedings to our oral skills. But disadvantages, you do have an increased risk of aspiration. Sometimes the volume is the thing that gets you in. We have problems with gastric emptying or reflux, and they're not tolerating it. Or osmotic diarrhea, in terms of like just large amounts of formula all at once causing diarrhea and dumping. In turn, continuous potential advantages. Obviously this is preferred method for like post-pyloric feedings, but slow infusion may improve tolerance, maybe giving nocturnally, depending on the schedule or the situation, can definitely be tolerated well or better with emesis or reflux. It does require a pump, so that's a disadvantage. You're attached to the pump, so that's inconvenient sometimes and makes it more difficult. May require supervision for children at risk for aspiration, because that feeding like doesn't stop. And we hear that a lot sometimes with parents when we talk about overnight continuous feedings or just continuous feedings that happen overnight. Okay, so let's say our patient comes to us on a continuous feed. They're doing really well. They're gaining weight well. They've got some good symptoms. So we're going to transition from a continuous to a bolus with an overnight continuous. So it's almost like bolus regimen light. Like, we're going to work our way into it, you know. So in my personal experience for this, the pro is you can find your initial tolerance to bolus feedings. You know, that's really kind of the nerve-wracking, tricky part for everyone involved is, oh, my kid's done really well on this slow 30 ml an hour drip. How do we know how much their stomach's going to tolerate? How do we, you know, that's the big question. So in this way, you can keep your volumes low during the day while also still getting your total volumes you need for growth. That can be helpful in terms of like reflux as well if we're having trouble with that, but we're still going to try to transition. Could help with weight gain. Sometimes I've had some kids where it's like bolus feeding, you know, well, there's multiple different reasons. Sometimes those bolus feedings aren't getting done overnight, depending on the situation, or not tolerating them overnight. So sometimes if you just convert from all of your boluses to continuous overnight, in addition to your boluses, then maybe you could have some better weight gain. Cons, it's inconvenient because there's a lot of like up and down in terms of like boluses during, you know, lots of scheduling. I do think, and it's more complex in terms of numbers. You know, here you're going to spout off numbers for boluses in mils, and then you're running your overnight feeding with total volumes and rates. It becomes kind of cumbersome. So you definitely need a family that is willing to kind of take on that task, and the schedule can be more rigid. You know, because if you've got certain number of boluses you need to meet during the day, and for whatever reason that didn't happen, or we're not tolerating it, now we're behind on volume, but we're not tolerating it, these are the things that come up. So in terms of case studies, let's just use this as an example, and we'll kind of use this for a couple of different transitions. So now we've got a 7-month-old, different from the previous one I'm talking about. Got his G2 placed about 2 months of age. He's tolerating feedings well. He's growing well, and planning to start oral feedings with speech therapy. So this is my big green flag that if we're going to start oral feedings, then I need to make something that's more physiological for you. Like, I want to optimize the amount of oral feedings and amount of time that you can get oral feedings in, and make it more normal so that we can work towards oral feedings. So he's on a hydrolyzed infant formula, concentrated 24 cal. He's been tolerating 33 mils an hour for 20 hours a day, 2 hours off the pump, which I prefer 20 hours a day. I don't know what you guys do at your facilities. When I first started, I was like, you must get 24 hours a day, which is, kind of, it's just really not feasible, because things happen. Like, what happens if you take a bath? You're losing volume, So I think 20 hours a day is perfect, especially for a little kid, but now we're going to move on. So 33 mils an hour for 20 hours a day is actually 660 mils. In the interest of growing a baby, things are always changing. So I tend to, if I'm going to transition to this plan, like, let's move up the volume to 700, because we're going to get more calories, we're going to get more volume, because we're going to grow. We're always moving, we're always making improvements. So I like to try to split it into half and half. Of course, I always tell people the beauty of tube feedings is it's kind of a blessing and a curse. There's a million different ways you can do it. So it's hard to decide which one you want to do, but also you've got a lot of options. So what I like to do is I like to start with half during the day and half overnight, trying to keep that overnight rate similar to what you've currently been doing. And the daytime boluses to kind of be similar, because this is where we're going to start kind of challenging what we've been doing. So we're going to condense these feeds to 4 feeds during the day and 10 hours overnight is, again, one way I might transition this kid. So we're going to keep our 30, we were doing 33, we're increasing in volume, we're going to go up to 35. We're going to do 35 mils an hour for 2 hours at 8, 11, 2, and 5. And this is what we will eventually consider our boluses, but we're going to make this transition hopefully the easiest that we can tolerate. So we're going to shoot for 70 mils 4 times a day, but we're going to run them over 2 hours initially and keep 10 hours overnight. And then I'll even tell families, if they're tolerating this for 7 to 10 days, then you can start creeping up that rate and on your pump. So these are only going over an hour. And then you give instructions to continue to increase that rate, so it goes over 30 minutes, and then we're working our way to boluses, which is kind of the next slide. So now we've done well, we're doing amazing, we're tolerating all these things, we've increased our rate, we're tolerating the overnight volume. Not to mention, if he's starting oral intakes, maybe he's taking an ounce during that bolus feeding during the day, and you're doing the rest over the pump. So things are moving well, we're progressing. So in my opinion, your next thing to do to work towards boluses would be to try to decrease your overnight feeding. Again, a million different ways to do this, depends on the patient, but this patient here, we're going to try to put that overnight volume into his daytime volume. So keeping our same goal, 700 mils here on the left. We're currently at 70 mils an hour, 4 times a day and overnight. So we're going to add a 5th bolus feeding and decrease our time overnight. And this again goes back to kind of the physiological aspect of working towards boluses. So 5 feedings a day sounds like a lot when you first initially think about it, but any kind of toddler is eating 5 meals a day, 3 meals and 2 snacks. They're eating 5 times a day. So this isn't really any different than a toddler or even an infant. These are 3 hours in between. This is just like more physiological. This is common for this kind of, if this was a typical infant or toddler. So we'll add a 5th feeding at 8 p.m. and then we'll just decrease our time overnight while we keep our same volume. So we'll go from 42 mils an hour for 10 hours down to about 8 hours, and we'll add that 5th feeding. So we're just moving our volume up to the day. And this parent preference to decrease time on the pump or just total volume depending on schedule, that depends on what they would like to do and how many feeds you're trying to get in during the day. Because sometimes I've added continuous feeding starting at 9 p.m. and they go until 7 a.m. and sometimes those kiddos do okay, works best for everybody, their volume stays low, their rate stays low. So again, multiple different things you can do, and hopefully if your parents are involved and have a preference, it gives you an idea of like what works best for them, because that's the goal, is for them to be doing this at home. So moving on to just bolus only, again, it's kind of similar back to the Texas Children's reference guide in terms of pros and cons. This is my personal experience. It's definitely more physiological, more scheduled flexibility. So, if you're doing all boluses, if you miss a bolus at 3 p.m., there's a good chance you can make it up at 4 p.m. and then kind of move your schedule back. Of course, this can definitely help to promote oral intakes, especially in a kiddo that's able to eat or drink. Like I said, maybe we work on eating or drinking 1 ounce at a time, and then we are bolusing the rest. Family satisfaction, more participatory meals. I have heard lots of families say that this is so much better. We're eating all together, I do think it is the easiest to comply with if they're tolerating it well. Cons, you do have to usually have to tolerate higher bolus volumes in order to get all your calories in. And then of course your increased risk for vomiting and aspiration. So going back to our same plan, we decreased our time overnight and added our 5th bolus. So now we're just going to move to putting all that volume in during the day. So really it's just about adding volume to your daytime feeds and decreasing your overnight. So it can end up looking something like the daytime feeds of 140 mils. You can start out at something like 70 mils an hour, which is what you've already been doing, but now you're just doing more volume. And that way we can see what our tolerance is for this volume now, just as we did when we moved from bolus and continuous overnight. So now we've got 140 mils at 70 mils an hour 5 times a day. And then from here, if we're tolerating this well, this is just a time and convenience thing. Sometimes I have parents that stay here because they say they tolerate it well. I can press the pump and then I can go do laundry or whatever, and their kiddo is happy with that. Or we're just gonna increase this rate on the pump. A lot of times we'll say 3 mils an hour every 3 days. So we'll go to 73 mils an hour, and if we're doing okay with that, we're gonna go up to 76 mils an hour the next couple of days. So we're just slowly decreasing our time on this pump, so that our goal rate is 140 mils an hour, so that our feedings are done in an hour. And then of course, from there, you can keep increasing the rate and get it down to 30 minutes. Or I think transitioning to gravity feeds alone per family's comfort level is really kind of the best way to go. Like, I can always encourage them, but you kind of just never know, and it's up to them to try. So you could start trying to give 140 mils as a bolus gravity feed after tolerating it for an hour if they feel comfortable with it, or you can continue to go up on your rates and things like that. So my mantra is kind of like, you don't know until you try. So this ends up being my answer often to families and providers. Like it just said, it's kind of like you got to try. You can't. I don't have a crystal ball. Nobody's got a crystal ball. I can't tell you if they're going to tolerate 140 mils over a bolus in 20 minutes over gravity until we try. So I can set you up for success in terms of like just those things that we talked about in terms of like going slowly, we're stretching our stomachs, we're making these things more tolerable, but we really just don't know until you try. So if that's your answer, it's I'm here to tell you that that's my answer too. Transition roadmap. So of course these things can come up and these affect your feeding regimen and your method given. Of course, seeing more vomiting. So now we've got to kind of take a step back and we can't keep continuing to go up on our rate. Just like that would be a solution to more vomiting. Feeds over the pump can reduce vomiting. Constipation can contribute to vomiting. So sometimes that's not my job. That's my practitioner that I'm working with. Can we adjust a med? Diarrhea, dumping, same thing. We got to make adjustments. Poor weight gain. So if we're on bolus feeds, like I said before, and we're really struggling to gain weight, maybe we got to go back to continuous feeds. Homeschool and home health schedule. Like I said, what works best for the family? What can be followed consistently? If this kiddo is not gaining weight and this family can't get 2 bolus feedings in overnight, then it's in my best interest and my patient's best interest to switch it to a continuous feed so that they get the volume overnight, So these are all transition road bumps that would get in the way of like that very nicely beautiful case study that we just went over, because it never goes that smoothly. So generally kind of my rule of thumb, if you've changed the administration method, you've gone from bolus to continuous, you've slowed down the rate, you've increased the rate, and that's still not helping with some intolerances, then, maybe this is the time we need to try a new formula. And I do think formula changes are scary. That's like, sometimes I hate changing formula because it's just, there's a lot of unknown. There's a lot more work. Will they tolerate better? Will they not? And of course, this is kind of my interpretation of like changing from like a polymeric to a peptide base, like why you would do that. Of course, I'm sure we've all encountered the patient that doesn't follow the rules. So I always say, in theory, changing from polymeric formula to a peptide base can improve nausea, vomiting, reflux, constipation, poor weight gain. Increasing to a higher calorie formula. So we might do this if they're unable to tolerate the formula volume with reflux or weight gain or vomiting. Powdered infant to liquid, unfortunately, sometimes this really works. Sometimes there's those families out there that you're really wondering if they're mixing that formula correctly, or getting all the scoops in that you want with the water. And so I've had a few patients really excel when you switch them to like a ready to feed infant formula. And then of course blenderized, and this is, I think, the new and upcoming research as well as like practice for a lot of these tube feeders. But so I'll give you a little lit review that I've done recently, but this can actually help, adding blenderized food or even blenderized formula can help with nausea, vomiting, reflux, constipation, diarrhea, and or poor weight gain. And this is like documented in the literature. I know sometimes it's about selling this to your physicians, to helping them, see this actually is better, this can be done, it's possible, and they see improvement. So this is now being shown in the literature. This is a big study, I believe, that came out of Boston Children's, Huron et al., health outcomes and quality of life indices of children receiving blenderized feeds via Enteral. The chart on the right, the table on the right, is just to show you that this is across underlying comorbidities. So there wasn't one comorbidity at this time that they were kind of like assessing to see if this was helping that specific one. It's kind of as like a blanket. It's been helpful for all different kinds of underlying conditions. And important to note, so BTF, the blenderized tube feeding group, was defined as having greater than 50% of their diet was consumed from a homemade table food or commercial blenderized tube feeding formula. And so my takeaway and recommendation for this is that it doesn't have to be 100%, and you still can see some improvements. So that's always, in terms of our topic today in terms of transitions, that can be helpful, is that we don't have to go 0 to 100. We can even just add some and see some improvement. So some of the results they found from these was ER visits were reduced, admissions reduced, respiratory admissions reduced, and definitely, winter's coming up, winter is coming. So this is like half the battle for a lot of your, for a lot of your G2 patients with these underlying conditions, is keeping them healthy so that they can continue to grow and not have setbacks. And then, of course, with GI-related symptoms, patients on blunderized tube feeding experience less GERD symptoms, which is in the study was the primary reason for trying a blunderized tube feeding: less nausea, vomiting, abdominal pain, upset, and diarrhea. Aspen actually has a really good YouTube series in terms of transitioning from blunderized tube feeding, all on YouTube, all for free. So this is a great resource. And of course, they're breaking it down in terms of it's like an educational for clinicians. This is something that you would understand. But it's super, super handy. So back to a case study specifically for transitioning formula. This was an 8-year-old female, 33-weeker, cerebral palsy, had chronic respiratory failure with trach dependence. She's feeding tube dependent. She actually was on an elemental formula with a GJ. When the formula recall happened, she was actually switched to a different elemental formula. Ended up getting a fund duplication and switched back to G-tube feedings. But during that time, the reason we changed was for her rapid gastric emptying, continuous diarrhea that wasn't improving, and having a diaper rash, and wasn't improving with her treatment with different topicals. So we actually transitioned fairly slowly, but this is not something that has to happen quickly. And a lot of the companies that have these pre-made blended tube feeding formulas will tell you be mindful of the different fiber that is in these formulas, and it can be beneficial just to do this slowly. And like I said with the study before, adding 25% might be all you need, and then maybe we stop here, but so we started at 25% of a peptide-based formula, mixing with her elemental formula, and then increased over time, 50%, 75%, up to 100%. And she did really well. Her symptoms improved. Her diaper rash improved. Her weight improved, but was never, at risk of not doing well. And actually, when I gave this previous presentation to my clinic practitioners, one of the physicians had asked, well, did her ER visits or her hospital admissions decrease? And they absolutely did. So it was super helpful. But I know changing formulas can be tricky and kind of scary, but there's lots of resources out there to help you, educate yourself, educate your families, educate your clinicians. And then so last but not least, transitioning off tube feedings to oral feedings. Ultimately for a lot of our patients, this is the goal. This is the main goal. So things to consider: obviously we want to keep our weight gain steady, that's appropriate for their age. Percentage of calories decreased. In my head, there's no rules, there's no set rules. So we want to decrease calories so that we're eating more, but we want to make sure their weight gain is constant. So is a lot, usually ends up in a lot more visits when it comes to outpatients, just so you're doing weight checks, and then adjustment in our tube feeding schedule, so there's more time to eat by mouth. So what does that mean? Doing something overnight and they're eating all during the day, or are we just going to decrease our volume during the day? These are things to consider, but the goal is we want more time to eat by mouth. This is from a resource from the Oli Foundation, weaning preparations for children fed by G-tubes. So this gives you, questions you can ask yourself, you can ask your families, you can ask your practitioners, to give you and identify if this patient is ready to transition off. Yeah, and usually we're asking these questions no matter what. So this case study, this is somebody I transitioned off of tube feedings onto oral feedings. She's 4. has Down syndrome, congenital heart defect, tracheostomy. She was G-tube dependent. This is her growth chart. The point of this is to show you that this was her growth chart throughout our weaning of her G-tube feedings onto oral feedings. So this is what you want to see. You want to see consistent, appropriate growth while you're weaning calories given by the formula. So our progression, we started in March 2023 and we decreased an ounce per feeding. You know, it doesn't sound like a lot, but when you've got, 4 or 5 feedings a day, that can make a significant difference. And then we come back in June and we decreased by ½ ounce per feeding. And maybe that's because 1 ounce didn't give us the weight gain we wanted. So we're going to meet in the middle and we're going to do half. And then in July and August, those were in between visits, like clinic visits, probably during some weight checks. And so we made changes then because like I said, it's all about maintaining that growth. So you're just going to be getting these weight. The best way to do that, in my opinion, is to be getting more weight checks and just seeing what their weight does over time. September, we decreased from 4 feeds down to 3 feeds, which is another 140 calorie decrease, which was a big jump. So it's like, we're making moves. We're going to see what happens. But then in December, her feedings and her weight was doing well. So we decreased 2 more feedings. February, we were down. Now we're back down to decreasing ounces. So we're still decreasing our calories by 144 calories a day. This was a 50% decrease. But over time, it's just making sure that our weight is doing well. We're getting good oral intake. We're talking to mom's comfortable. She wants to move on. And then in April, we decreased to 1 feed. In July, we stopped all her G-tube feeds altogether. And she did really well. In 2 things, I want to point out, this took over a year. So this is not necessarily something that has to happen quickly. And I do feel like sometimes when they're older, it can take more time because we're working on eating more foods by mouth. And the second thing is her feeding therapist actually emailed me frequently. This mom is actually Spanish speaking and they see a Spanish speaking feeding therapist, which is wonderful. But she was emailing me frequently saying, oh, she's doing really well. Mom has some questions about this. It helped that we were on the same page and I was able to reassure the feeding therapist, who again is to be able to reassure mom, yes, you're doing well. We're doing great. So with that being said, I think it's important to know, like I said in the beginning of the flow sheet, feeding therapy is vital. Like there's approaches that can help these kiddos get over their aversions and improve their intake to where we're getting off of these 2 feedings. And this SOS feeding therapy, sequential oral sensory feeding therapy, is something that we have found to yield better results when we're kind of treating the kid as a whole and treating them as like, well, we're going to take your lead on these kinds of situations. This is just an interesting, they had top from the SOS website and top 10 myths of mealtime in America. So these are just interesting things to note, that they're myths that are not absolutely true. One that I think is interesting is that the myth that eating is easy. I think sometimes parents and clinicians can get frustrated, or myself can get frustrated because, well, this should be easy. Like, it's just food. Food's great. It's wonderful. It's beautiful, but it's not easy. So it's the most complex physical task that human beings engage in. Requires one of your organ systems only tasks. It requires all your organ systems to work correctly, which, and definitely in some of our patient population cases, not the case. They're working extra hard for these organs to be communicating with each other. Every muscle in the body is involved. And eating is the only task children do which requires simultaneous coordination of all your sensory systems, which coordination of sensory systems can be hard for an adult. So this is, it's helpful to have techniques and therapists that can help you with therapy and at home. And this is, I think, the way that you get off of your tube feedings faster, is feeding therapy for sure. Okay. Any questions, thoughts?
Thank you, Haley. While everybody's taking a few minutes to maybe type in their question to the question feature, I will point out that in the handout section, you do have access to the references, your certificate, and a copy of the slide deck. So if that's what you're looking for, you can go to the handout section, but we will also email you the references and certificate as well. So if you don't get a chance to go to the handouts section of this, that's okay, because there will be a follow-up email as well. Okay, a few questions here, Haley, and we've got about 7 minutes. What is your facility's protocol for tube placement refusal when it's deemed medically necessary by the medical team?
Ooh, what a good question. Those are difficult and tricky because you want to try to respect the parents' wishes, but I think it ends up being a lot of, sometimes we've worked with parents and tried to show them, we're going to follow you every 2 weeks, every 4 weeks, so much more closer follow-ups, and show you the reason for the need for this. And then unfortunately, if there's still more refusal, sometimes we've gone to hospital admissions. So, this is a difficult case and kind of becomes a social case because this family is refusing what's medically necessary. But it can also be a tool in terms of like, okay, well, we can put them in the hospital and admit them and try to tease out any other thing that you think is the problem here with 24-hour care and 24-hour nurses to gather that information, and can kind of be like a eye-opening thing. Or unfortunately, if we have to get a hold of DHS, that's our option for the best interest of our patient. But do we have a protocol? No, it's just kind of patient and provider dependent.
Okay. A follow-up to that is, do you guys have an ethics committee that ever has to get involved?
So I know our clinic specifically does not have an ethics committee, but we are under an umbrella that's combined with the hospital that we work with, and the hospital does have an ethics committee that we could utilize if we needed to.
Okay. The next question is, you referenced earlier in the presentation your team approach, and your team has grown over the years since you've been there. Who all is a member of the team that's involved in taking care of children with tubes?
Oh, well, I feel I'm blessed in the clinic that I'm working with, because I actually see patients at the same time, a nurse practitioner, a PA, and then a physician. So we each have days where we're seeing these patients at the same time. So directly, it's me and a physician, and then we have some nurses on staff that can help troubleshoot things or change G-tubes or give advice and things like that. And then I would say, not in our clinic, but like I'm saying, a part of the team is the speech therapists and those feeding therapists, giving us direction in terms of like how well they're doing on their tube feedings and the safety of it.
Okay, great. Switching gears a bit here, you mentioned earlier aspiration, vomiting, etc. What is the standard of care currently for pediatrics and checking gastric residuals? So this dietitian is currently working in long-term care in adults, and so it's just looking at how do you look at that from a pediatric perspective?
It's my understanding that the literature doesn't support checking gastric residuals because there's no clear defined amount and like protocol as to what that gastric residual volume means. So in terms of pediatrics, we do get that from time to time. If they've come from a different facility, they're checking residuals. We actually recommend that they don't, and that what you're basing feeding tolerance off of is the other signs of intolerance, like vomiting or reflux or diarrhea.
Okay. This next question is a great question, because when I was practicing in pediatrics, I ran into this all the time. So I'm glad somebody just asked this. Have you experienced any pushback from feeding therapists regarding taking a slower approach to weaning off of the tube? This RD has encountered some philosophies from clinicians that sacrifice patient growth or weight gain temporarily, which they feel is okay to get them off the tube feeding faster. How would you navigate this situation?
Oh, I'm uncomfy. That is hard. That is very difficult. The worst case scenario, I've had a patient come in who has a tube feeding and this is just actually really recent, and had recommendations to stop all of her feedings by tube and drink like 1 Pediatric a day and try to gain, and eat. And she came in and had lost tons of weight. And worst case scenario, I tell her, there's many ways to do this, and I would not have recommended this. So I like to try to have a frank conversation and be open and transparent in terms of like why we do these things more slowly. So I don't end up having a lot of conversations with feeding therapists at the time. It kind of usually just comes through families. So it's a lot. The explanation I've started to give, because even families, they get anxious to start getting off these tube feedings, is if you will stick with us and do this slowly, and we can decrease this over time, the likelihood of them not needing this tube anymore is higher because we've been consistent and we've done it slowly. But if you come in and we're not following directions or instructions and our weight is faltering, we're going to have to utilize our G tube as a tool and add this back. And now we've taken steps back. So recently I've been trying to explain to families, if you can follow this consistently, I promise we want the same thing. We'll decrease this formula as their weight does well, and you will get this tube out sooner if you are consistent and we do this somewhat slowly.
Yeah, that totally makes sense. And one of the things I always used to do is like if it was cold and flu season, I was more reluctant to wean quickly because knowing that patient history of they get a cold and they stop eating entirely, right? And then was also something I always thought about. Another question here, and we have time for maybe 2 more. Are you okay with that, Haley?
Yeah.
Okay. For consideration regarding G-tube or an NG-tube, what are the considerations when the patient has rapid weight loss in 3 months due to fatigue, unable to eat sufficient calories as their worsening medical condition? So this individual gave like seizure activity as a specific. In this situation, when would you consider having a G-tube necessary? I think they're looking for like maybe a certain percentage of weight loss, or like when would you start having that conversation, maybe like a number of.
I do think that there's criteria for malnutrition, and multiple different resources. So I would say, one, especially if this is something like seizure activity, is this going to get better? So like, do we have a chance to improve upon our medical situation and like start eating again by mouth? And if the answer to that is no, then we really don't have any reason not to just put a G tube in and, go down that route and optimize our nutrition that way. But I guess I would go off of, I'm trying to recall, I think it's like 10%, 15% weight loss. That seems kind of high. So let's say 10% weight loss. And I would say if it's consistently happening, then you've got to do something. You've got to have an intervention, and that maybe that's even an admission to talk about NG versus G tube kind of situation. I'm going to give it a 5 to 10% weight loss. You've got to do something,
Yeah, no, I agree with you. Yeah. Last question. What if a patient is very anxious about eating in general, that they're refusing to eat because of this anxiety, and they got very comfortable with the tube feeding? So they have a tube, you're trying to get them to take oral, but they're super, super anxious about it. How would you navigate this?
So this is, I feel like ARFID territory. Like, this is tricky. Great question. I would recommend like some counseling, honestly, to work around the anxiety of food. And like a lot of the new literature, I had a dietitian that I work with that went to like a feeding therapist, SOS feeding like seminar, and they talked a lot about ARFID and like feeding disorders versus, pickiness and things like that. And so RFID, I think, is, restrictive food intake disorder has got a magnifying glass on it. And so I think in terms of anxiety, you're running into a psychological disorder that needs psychological specialists. And so I would recommend counseling and to try to navigate what's causing so much anxiety. And unfortunately, you're kind of at the mercy of them working on that while they have the tube. And I've even had one patient that was like this, and we had to have a conversation with him. He had had an NG tube for a year. And we said, all right, we're coming on to a safety issue here. Like, we either need to make some movement in terms of eating by mouth, or we're going to have to do a G tube. And unfortunately, you don't ever want to put that on somebody who already has anxiety, but that's just best practice in terms of safety. So, but my answer would be, you might need some psych help, counseling help to figure out what's causing the food anxiety.
Yeah, no, great answer. Great question. For clinicians out there working with kids with that condition, that is not easy.
Yeah.
So that is all the time we have for today. Like I said, they're in the handout section. You can have the references, your certificates, and a copy of the slide deck. If you don't get them out of the handout section, don't worry about it. We're also going to send you an email with that information that also has a link to the post-survey assessment. So please take a few minutes to fill that out for us. As always, Haley, thank you so much for sharing your knowledge and your time and your passion for this patient population. We really appreciate it here at Functional Formularies. And I hope everybody has a wonderful fall, and we'll be seeing everybody soon.
Thank you.
Bye, everybody. Thank you for attending.